All right, we are recording.
All right, welcome everyone to our virtual molecular tumor board and our variant type series. And I'm really happy that Moushumi Suryavanshi is here today, and she's actually in completely different time zone, so it's quite late at night already, and she still managed to join. She's a molecular pathologist at the Rajiv Gandhi Cancer Institute in New Delhi, and she's working in different fields. She's been part of the ISUP grading committee for the new WHO classification for prostate cancer, and today she will talk about HAR and HRD scoring in cancer, and I'm really looking forward to that.
First of all, thank you for giving me this opportunity. I'm Dr. Moushumi and from India, and I'll be speaking on HRR and HRD in cancers. So before I begin, there are various DNA repair pathways in our body, and we commonly know about two pathways. We are just talking about two of them, and they are the homologous recombinant and the mismatch repair pathway. But actually, there are many other pathways like nucleotide excision repair, base excision repair, but we are presently not talking about them because there are only drugs available for homologous recombinant pathway and the mismatch repair pathway. For mismatch repair pathway, we have immunotherapy, and for homologous recombinant repair, the approved drug is the PARP inhibitors. And this homologous recombinant repair is a very potent kind of repair pathway, and it is very robust and compared to the other pathways. So this is a very important repair pathways which is there. So with this background, I am not able to move my slide. Okay. So what is the origin of these HRD or homologous recombinant deficiency signature? So mutations are an archaeological record of exposure to mutational process. So what I mean by this is that there are certain processes which cause mutations, like maybe aging, ultraviolet rays, and certain types of carcinogens like aflatoxins. So they have a peculiar kind of signatures. So by signature, I mean if the mutations are divided into 6 groups like C2A, C2G, C2T, T2A, T2C, and T2G, then they can be categorized in different signatures. And these signatures are based on thousands and thousands of studies from the tumor whole exome sequencing from the TCGA, and then using a bioinformatic algorithm or machine learning mechanism, these signatures are calculated, and certain signatures are peculiar for certain types of insults which the tumor has been infected with. Say, for example, if the tumor has got a smoking kind of insult, or the cause of the tumor is smoking, maybe as in lung cancer, there will be a peculiar signature. And similarly, for homologous recombination kind of deficiency, there is also a peculiar signature. So there are around 30 types of signatures, and this is the signature 3 which is there, but this is detected only on whole exome sequencing. Similarly, for copy number also there are these signatures. So combining these two, the single nucleotide variation signatures and the copy number signatures, there is a peculiar signature for a homologous recombinant deficiency which occurs if it is present in tumor. So what I'm trying to say is that the concept of looking for HRD is come from like your tumor mutation burden from whole exome sequencing, where these are signatures. So rather than doing a whole exome sequencing and looking for these signatures, we are trying to have smaller tests which can look at these signatures without doing the whole exome sequencing. Okay, so homologous recombinant deficiency can be looked up by various mechanisms. So the ones with the smileys are one which are commonly known. One is the germline BRCA1 and BRCA2 mutations, because these are the genes which are usually associated with the HRD HRD. And then there is somatic HR pathway mutations. And then the functional HR assays, which I'll be talking about right now, I've just put a star there because this is a very important. I feel this will be one of the important tests in future. And then the genomic scar assays, which is your HRD score, which I think we are going to talk more about today. Then the mutational signatures, as I already mentioned, these are based on whole exome sequencing. And they are usually not used as a routine test. Then gene expression signatures of BRCA. These can also be seen, but these are not used as test. So what we are using are germline BRCA and germline non-BRCA are the other HRR pathway genes which are used. These are the tests, these are the biomarkers which are already available in the routine diagnostic practice in cancer patients. So coming to the HRR gene, so there is no universally defined HR homologous recombinant repair genes, but there are various trials which have used HRR genes, and the gene list is different in different trials. But there are certain genes which are common, like your BRCA1, BRCA2, ATM, BRIP1, CHEK2, PALB2. So these are the common ones. But besides these, RAD, B, C, D, are also commonly seen, FANCA, CHEK1, and CDK12. So these are also mostly seen in most of the gene lists, but definitely there are no universal gene lists. So if you're planning to have a universal gene list, you should at least have these common genes if you're designing a test of this sort. So HRD, basically we are trying to know the signature, and what determines the HRD, as I told you, that not only the mutations, but other processes like probably methylation or undetermined causes can lead to this kind of genomic instability, which is due to homologous recombinant deficiency. So to know this, there are these HRD score, which is based on the sum of three components. One is the loss of heterozygosity, then is the telomeric allelic imbalance, and the third is the large scale state transition. By loss of heterozygosity, it is meant, and we have a bioinformatician here who would be better understanding this, is meant that the number of regions of representing one parental allelic via loss of heterozygosity, it could be either copy number neutral or loss, and it is longer than 15 MB but shorter than a whole chromosome. Then the telomeric allelic imbalance is the number of regions which have either a copy number gain, loss, or a loss, and this is extended to one of the subtelomeres, but do not cross the centromere and is greater than 10 MB in size. So that's the definition of telomeric allelic imbalance. And the third component, which constitutes the HRD score, is the large scale state transition. It is the number of chromosomal breakpoints, that is the change in the copy number or allelic content between the adjacent two regions greater than 10 MB, but not comprising the whole chromosome. So as you can see in this figure, that there is loss of heterozygosity, that there is and there are two breakpoints. So this will have one LOH score, and plus if there is two breakpoints, so two breakpoints from large scale transitions. So that's how these scores are added. The HRD score is basically, as I already told, a sum total of loss of heterozygosity and these TAIs and LST breakpoints. So I will go into the detail of these, how these scores were, why these scores were added up. But before that, since this HRD score for now is only used in ovarian cancer, and it will be soon coming to other cancers like your triple negative breast cancer and your prostate cancer. But presently it is only approved for ovarian cancer. So just looking at the genomic profile, which you can see in this pie diagram, that what you find is that almost more than 50% of the ovarian cancer have are HR deficients, and there are only some 15% cancer which are probably cyclin E, which have probably cyclin E amplification, which is mutually exclusive with HR deficient patients. So besides that, there is almost more than 50% of the patients who have HR deficiency, and these HR deficient patients are eligible for PARP inhibitor therapy. So, and there are various mechanisms of HR deficiency. It could be either a germline BRCA1 BRCA2 mutation, somatic BRCA1 BRCA2 mutation, some BRCA1 promoter methylation, which is seen in around 10% of the patients, CDK12 mutation, and similarly other HRR genes mutation. And there are some other pathways by microRNA regulation or maybe MMR or other regulations, which could also, it is though doubtful, comprise a part of HR deficiency kind of signature. So there is a huge group which can be picked up by using the HRD score, which is a surrogate of picking up all these things, all these mutations or all these mechanisms without actually looking at each one of them. So presently, there is FDA approval for PARP inhibitors. For ovarian cancer, it is a germline or somatic BRCA mutated. And these are the different generations of PARP inhibitors: olaparib, niraparib, rucaparib, and talazoparib. And on ovarian cancer, the first three, olaparib, niraparib, and rucaparib, are approved, and they're approved for germline and somatic BRCA1 and BRCA2 mutations. And in HER2 triple negative breast cancer, olaparib is approved for BRCA1 and BRCA2, and tazoparib is approved. For pancreatic cancer, only olaparib is approved, and for castrate resistant prostate cancer, both germline and somatic HRR genes, not only BRCA1 and BRCA2. There is a list of around 15 HRR genes which are approved, and in germline and somatic, and even in liquid biopsy, they are approved. And for olaparib and for rucaparib, only BRCA1 and BRCA2 germline or somatic mutation is approved. And for the HRD score, which I'll be discussing after subsequently, for olaparib, HRD positive, that is a score which qualifies for positive, is approved in first line along with bevacizumab, and it has shown a very good survival benefit. And in niraparib, which is another PARP inhibitor, it is approved in late line when patients who are HRD positive. And rucaparib, it is approved for all comers who have HRD LOH positive, who are LOH high. And in second line maintenance, it is approved, along with, of course, the BRCA1 and BRCA2 mutations, which I have already mentioned. So these are just to show you how the PARP inhibitors in these patients have benefited the patients of ovarian cancer. And here you can see that this is placebo plus bevacizumab, and this is olaparib plus bevacizumab in patients who are HRD positive, and there is a clear-cut survival benefit. And these patients are the ones who also had BRCA1 mutations. And on the right-hand side, there is another graph where again the HRD score is positive, but these patients were not having BRCA mutations, but still there is a clear-cut benefit of offering olaparib and bevacizumab in first line as a first-line therapy in these patients. So that is the importance of using this, and that's why this test has become very popular, especially for ovarian cancer. And I think we all are trying to start it, or we already are doing this test. And then this is the Ariel 2 study based on which the LOH criteria was approved. And here you can see again in the graph that the patients who are BRCA positive along with LOH high, they have a better survival response to rucaparib compared to the patients who are just BRCA positive, and also in green, the patients who are BRCA wild and LOH low. So this is another study where there was a response and resistance to rucaparib treatment in patients of high-grade ovarian cancer. So again, the same thing is highlighted, that the patients who are BRCA mutant along with LOH high will do better if they are treated with these PARP inhibitors. So, and not only the PARP inhibitors, these patients also respond well to platinum. So most of them are platinum sensitive and also sensitive to PARP inhibitors. So presently there are two companion diagnostic tests which are approved. by FDA. One is the Myriad Genetics My Choice HRD CDX test, which includes the which comprises the HRD score, which is a continuous score from 0 to 100, and it includes the loss of heterozygosity, telomeric allelic imbalance, and large scale state transitions, as already mentioned. So this here the cutoff score of greater than 42 is taken as positive. And another test which is approved companion diagnostic is the Foundation Medicine Foundation 1 CDX test. It was approved in 2018, and here it detects the percentage of genomic loss of heterozygosity, just LOH, compared to the previous one, which is also detecting the TAI and LST. Here only LOH in tumor samples of ovarian cancer are detected, is used as a cutoff, and the cutoff of 16 is used. So coming to the first test, the Myriad My Choice CDX, it is again, as I have already explained, it comprises as a sum total of three things: loss of heterozygosity, TAI, and LST. So it also includes two genes which are reported, BRCA1 and BRCA2. So the cutoff is 42, and it was later also lowered to 33, but for I think most practical purposes, most of the people are considering 42 as the cutoff. So how this score was derived, I'm not going to the statistical thing, but just for basic understanding for people like me, probably who are molecular pathologists and not bioinformatician or statisticians. So it was in a cohort of 859 ovarian tumors, and it was seen that none of the scores alone, that is the LOH, TAI, or LST, could predict a clear cutoff. But when these were combined, so there were clear cut two populations, one which responded to the PARP inhibitors and the one which did not respond, and the cutoff could be set somewhere between around 42. So that's how the score cutoff of 42 has been derived. And when this cutoff was checked in the patients who were having BRCA deficiency or BRCA mutant versus the patient BRCA intact, again it was found that this score was coming to around between 40 to 45, around 42. So that's based on those kind of statistical findings. So this score was derived. So this Myriad My Choice test has been very popular with so many trials, and many approvals have been given based on this test. And Nova trial, Quadra trial, Prima trial, they have all used this test, and Pelova trial, which has approved olaparib plus bevacizumab in the first line, also used this test and used 42 as the cutoff. So what are the acceptable criteria? So, of course, the tumor is more than 20%. Any subtype of ovarian or fallopian tube or peritoneal carcinoma is accepted. So, high-grade serous is the usual morphology, but clear cell and other are also accepted. The frozen tissue is also acceptable, and the cell blocks are acceptable. The unacceptable tissues here are the brain metastasis, bone metastasis treated with acid decalcification, and endometrial tissue. So they obviously, like other tumors, pathologists should review the case, and the block with the highest tumor percentage should be selected, and tumor size should be more than 25 square millimeter. That is the recommendation. And coming to the second test, which is the Foundation 1 CDX, it is a huge panel which has 324 genes, and it has 14 HRR genes. And this was approved as already shown in the Ariel 3 trial, and the cutoff has been 16, is of 16. So besides your ovarian cancers, as I already told, the prostate, breast, and pancreatic cancers also have mutations of HRR gene. So rarely their other cancers can also have, but these are the cancers which are usually have a bigger number of HRR gene mutations which can be associated with them. But and also we are testing HRR genes in prostate cancer, breast cancer, especially the triple negative breast cancer, and pancreatic cancer. So around 20% of prostate cancer have HRR gene mutation. These mutations, and I'm saying mutation, these can be germline as well as somatic mutations. And your triple negative is around 16%, and pancreatic is around 26%. And of course, as you can see, the predominant ones are the BRCA mutants, and there are other non-BRCA HRR genes which also are found. So that's why presently we don't have enough data. So that's why only HRD score versus HRR genes is approved for just ovarian cancer. And very soon, as we have enough data, we will have the approval for triple negative breast cancer as well as pancreatic cancer. So, but that has to be kept in mind. The same cutoff will not be applicable to all the tumors. So as for ovarian, like 42 is the cutoff, probably there will be different cutoffs for different tumors, but that still has to be seen. But of course, the same cutoff may not be valid for other tumors. There will need to be a validation on enough number of samples to develop their own cutoffs. So, and the question is like, this is a problem we also face when we do HRD square. The people always expect to get a results. So because of technical reasons, and these are the results from various trials, you can see that around 15 to 16% of the cases did not yield a score because of technical failures, because the tissue quality is very important. And especially in HRR genes, when the problem we are facing is that it is a bony tissue, it is an old tissue, and we have also have a good rejection rate in prostate cancer, especially because the tissue is old, and the metastasis to prostate is usually bony metastasis. So that's why the yield and the uniformity is very poor. So I had put a star on the biomarker, that is a functional assay. So this is the functional assay, which I feel, and there are a lot of trials going on for this assay, which might be a good substitute or maybe even a better substitute to HRD score. So this is the RAD51 functional assay, which is assay with RAD51. I'll not go into the details, but comes into the homologous recombinant deficiency mechanisms later in the stage when the other things are done. And if it is proficient, like if it is high, that is the HR mechanism is proficient. So, but if your RAD51, if you can quantitate it is low, that means the HR mechanism, whatever reason it may be, is deficient. So this test is based on immunofluorescence and is done on confocal microscope, and it is classified as a score of greater than or less than 5 RAD51 nuclear foci, which could be positive. So not going into the details of this, what I want to show you is the sensitivity specificity of this test. So it has in the PDX model yielded very good results, and it's already in the trials, and you can see its comparison with the HRD score. Though the sensitivity is lesser, but the specificity is far more, and the accuracy of RAD51 score is far more. So I feel, and it will be a cheaper alternative to the HRD score, and especially in countries like ours in India, where paying so much money for HRD score is a big issue, and people do want to get tested, and we have a lot of ovarian cancers. So in those scenario, I feel a cheaper test will be much useful. But yes, but there are also limitations to these genomic instability tests. Like as I told you, that these are based on the signatures, that on a tumor there may not be just one signature, there may be other signatures, and the tumor tissue may have been taken at some point of time, and the therapy is offered maybe later on. So there may be other signatures which have come up. So those are not accounted for. That is one thing that has to be taken into account. And I feel in future, probably single cell sequencing kind of solutions would be available, where you can sequence, do the single cell sequencing and look at the different types of signatures which are present on the tumor, and then take a call what kind of therapy the patient has to be offered. So, and also once the patient is started on PARP inhibitor, there are reversion mutations. These are there are many examples of these kind of mutation. The patient who has a BRCA mutant converts to BRCA wild because there is correction of the original mutation, and your HR and the PARP inhibitor therapy, which was supposedly given to work against the BRCA mutation, stops working because the BRCA mutation has reverted back. So that is another mechanism where the your these HRD scores or your PARP inhibitors fail even to give you a result. So then there is another thing which I clinically get a lot of questions about, is the relation between HRD and TMB. And if you look up the literature, so the literature is very varied. So some people, some of the publications say yes, there is a positive, they correlate proportionately, and some say they don't correlate. So we don't know the truth, but this is a recent article which I found, and I thought I should share it with you, that how it correlates. So there was some, this is based on some 9,000 plus TCGA data. And what the interesting finding here is, so these red dots are BRCA mutant patients. So, and on the x-axis is the HRD score, and on the y-axis is the tumor mutation burden. And you can see that most of the times when your HRD score is high, your tumor mutation burden, if the cutoff is 10, is also higher. But there are cases where your BRCA mutation is there and your tumor mutation may not be that higher. So yes, mostly it should be, but it may not be. But there are these blue dots. These are the patients who have your MSI. These are the light blue dots, and the pole mutated patients where the TMB is very, very high, but your HRD score is very low or practically zero here. So this is a group. So it doesn't make any sense of doing HRD score in the patients who are MSI deficient or pole mutant. So this category where the MMR repair mechanism is not functioning, your HRD score is unlikely to be high. So that's what that's data is showing. But your BRCA mutants can have a varied score, but of most likely it should have a high tumor mutation burden. So, and this is the from the paper. So here they have shown some 18 tumors where the tumor mutation burden and the HRD score correlated proportionally, but there are other, and this included ovarian cancer tumor and the prostate cancer tumor, but there were also other tumors amongst the 30 tumors types which were tested, which did not correlate. So there is not always a simple correlation, and it depends on the tumor to tumor, as well as about the based on the MSI or pole mutant status. So another place where I feel HRD score is helpful, and I have personally used this, is then when you find a VUS on HRR gene. So you've done a HRR gene testing and you're finding a VUS and you don't know how to treat it. But if your HRD score is high, and I feel so that is the time when your VUS is actually pathogenic and the patient can be offered. So you found a solution there. So that is one place where this is like an example of a case where patient had a BRCA1 VUS and in the 3 members of the family, and then HRD could be an answer for this kind of situation. So there are challenges with HRD. HRD test fails to reliably identify the group of patients who will not respond to PARP inhibitor therapy. So you have to realize that this is not the God test. It is not absolute. And HRD assays do not provide dynamic readouts, uh, a dynamic readout, and only valid for the time point at which the sample is obtained. So the biology of the disease may change. There may be other insults added to the HRD that has to be kept in mind. So we need to combine them with other predictive biomarkers as the PARP inhibitor therapy evolves to include the combination therapy. And the future is there will be multiple markers. There will cannot be just one marker like your immunotherapy. It cannot be just one. So it will be a complex algorithm of your immune responses, your genomic features, and your functional assays, and then combining them together using the AI models or machine learning models to give you some time of a HRD gram sort of picture. Then this is a case where, just to show you, this is a real case. This is a 48-year-old female who had a serous ovarian stage 4 cancer, and the HRD score was 72 with the high, and we are using the Kaizen HRD panel, and we have a cutoff of 65, and by those standards also this is 72 is a high score, and there was high loss of heterozygosity, LSD, and TAI, and there was also a germline BRCA1 mutation in this patient. It was a frameshift mutation, but the patient was offered olaparib and bevacizumab, and the patient did not respond to PARP inhibitor therapy. And I think I have already answered this thing in my presentation, that these are not the absolute tests. There may be other mechanisms which are working, and or also there could be reversion BRCA mutations which happens, and the patient's BRCA mutation reverses, and there is no use of offering this. So there are multiple things. We are just looking at HRD. That's what I want to say. So though we have done few cases, and I'm just like to share them, though it is not in a very well formed because we've not published it. And but for HRR gene, especially this panel, this is our like 4 or 5 month old panel where we have done 40 cases, and most of them are for prostate. And because we earlier had a bigger panel which we were using for ovary, so for this particular panel, which has 15 genes which were there in profound trial, so which are mostly used for prostate, and one breast TNBC has been tested, and 10 ovarian cancers have been tested. And as I told you earlier, we have had 4 prostate cancer patients which were rejected due to low uniformity. And the major problem in prostate is the old tissue and also the bony samples, and the mutation which were found mostly were BRCA1, BRCA2. Somehow we are also doing single gene BRCA1, BRCA2 mutation, so probably they were missed and they were not tested. ATM, RAD51, CDK12, PALB2, BRAD51, and RIP1. So these were the mutations commonly found. And we are also doing HRD score, where as I told earlier, our cutoff is 65. We've done some 17 ovarian cancer patients, and 5 of them have had high HRD score, and 3 of these patients had no HRR mutation but high HRD scores, and the other ones had BRIP1 and PALB2, and also the HRR G score includes HRR gene, where there is CHEK2, which is a pseudogene and which does cause lot of false mutations, so which we have to be very careful about. So that is my like little experience, which I could just gather from our few tests which we have done. And with that, I'd like to thank you and show you this painting. This is by Shoshanag Dubiner. So this is a cell garden painting. So I always show like this painting because this is like the world of molecular and immunotherapy. There is a lot of creativity and there is science also, and there is art and there is science. So it is where the art and science collaborate. And with that, thank you. And if there are any questions, I'll be happy to answer.
Yes, thanks for this very great overview. So I'll open for questions. And I already see a hand. Damian, go ahead.
Yeah, thanks for the great talk. Actually, I have 2 questions. So the first one is, and I might have missed it, when it comes to different tumor types, we don't know so much about the HRD score. Do you think we need different cutoffs for every single tumor type, or do you think it's going to be the same for everyone as we learn more? And the second thing is regarding the CHEK2 pseudogene. I'm not sure if that's a comment or a question. We'll see. So we frequently come across CHEK2 variations when in our molecular tumor conference. And when we look into the data, CHEK2 is sometimes included in those trials with PARP inhibitors, but so far I haven't seen a single case report that produced a response with a PARP inhibitor and a CHEK2 mutation. So I completely agree that I think CHEK2 is something that we should be very careful with.
Yes, yes. Thank you for validating it, because when we had started, I thought we have a CHEK2 mutation. Then I did the second test for validation, again the same mutation. Then I realized there is some problem. Then I read about it. Yes, it was there. And about your first question, so there is right now there is enough data which is coming out on different tumors. So triple negative breast cancer and prostate cancer definitely will have HRD score. coming up soon. And probably they will have different cutoffs, but that still has to be defined. So what most of these things are coming from the companies which are sponsoring the drugs. So you have to realize that, and they usually go for a companion diagnostic thing. So based on that, they develop a score, and which is very costly, especially for people like us in India. So using the same test is very costly. So we have to design our own thing, and maybe sometimes you do some validation. Validation is also very costly, you see, for NGS, do our sort of validation and come to a score. But definitely whatever literature is coming out, there might be different cutoffs.
Thank you.
Hey, Marcos, I think you have another question.
Yeah, thank you for this very nice talk. Just a short comment to the CHEK2 problem. I totally agree with you. I think some of the most common CHEK2 mutations in official databases that are clearly marked as pathogenic hotspot mutation are in 99% sequencing artifacts, and you can sometimes already see what sequence technology they used or which aligner they used. And so I think this is very interesting, and maybe it will be interesting at later times to see if variants in CHEK2 or so, if they add to HRD to categorize variants in their function, because sometimes you have a lot of unknown variants, and if you find them in HR proficient cases, you might have a reason to reclassify them as likely benign. And I think we will get a big amount of new interesting data with this technology.
Yes. Yeah, thank you for the comment.
And maybe I have a question. Maybe this is a misunderstanding on my side, but you said that your functional assay has a higher accuracy. Is that related also then to resistance to PARP inhibitor? So could you basically check whether or not
is it
the functional
yeah,
assay, whether this also relates then to resistance to PARP inhibitor, or like what exactly is the accuracy related to?
So basically RAD51 comes later in the HR mechanism, the repair mechanisms. So whatever may be the reason of the deficiency, so if it is working, that RAD51 is working, so that means that there is no deficiency. But if it is not working, so that means that there is a deficiency. It is an indirect, it's sort of a surrogate to tell you that something is wrong in the HR mechanisms. And it is far easier. It's like a immunofluorescence. It will be easier to do. Of course, it will have some rejection rate because it is immunofluorescence. So there are multiple papers there, and it is also, I think there are 3-4 trials. If you want, I can share with you the name of the trials. I did not mention it because I thought it will be slightly out of context, which are actually using this test. And maybe in a year or so, the results will start coming up. So that they have already shown. And if you just looked at, I had shown you a PDX model where the response to the PARP inhibitors versus the RAD51 score and everything was matching with your HRD. So
basically the one case you had where you didn't show any response to PARP inhibition, you could basically try to check at some point with the functional assay.
Yeah. Yeah, but
So
we have to develop it. Yes, I was thinking that we should have something. I'm trying to get some money, research money, so that you can develop such, because it's quite easy, possible to do that test. So I was thinking that we should try that. And yes, that's in my mind.
Yeah, that seems like a very interesting way to go then to validate these cases.
Neat. Yeah, I think that sounds amazing. So I did get a message in the chat from Dr. Darabi, and it looks like there is a recent publication about kind of these secondary BRCA mutations that can arise. So I don't know if you want to discuss briefly.
Sure. Thank you so much. Great presentation. I just notice that you presented some data on BRCA, actually reversion mutations, which is really dear to my heart. I just published on Saturday a brief report on 75 BRCA reversion mutations pan-cancer. So I asked if it's okay if I make a comment. So this is really important in a clinical setting. That I also presented an original data of this at ASCO as a poster. And then the main question is, okay, what is next? When we have these patients that they are resistant to platinum-based therapy and PARP inhibition, and what we do next. So this is a question that there are some ATR inhibitors or some studies going on in combination of ATR inhibitor, bringing back the platinum as a combination therapy for these cancers that are resistant to therapy with PARP. But this, I think more publications, if you see some of these reversion mutations, please go ahead and publish. There is a UK database that you can also deposit your data on BRCA or any of the HRD reversion mutations to that database. So everyone can go easily access that data. It's very hard to report those out from the laboratories. I think the people from the lab can comment on that, but the laboratory that we work with to report those cases are only reporting on patients that have been treated with PARP inhibition or platinum base. So this is additional 75 cases to report, and it is in line with what you presented. Thank you.
Thank you. Thank you. So these are how many cases were after PARP inhibitors, and like how many after platinum? Any?
So there is very limited.
And also share your publication. I want to read it.
Okay, I'll share it in the chat. Is very limited number of outcome data, unfortunately, that we have. So we don't know exactly the total number, but we have 75 cases. There are 32 BRCA1 and 43 in BRCA2 in different tumor types. Of course, we have the most in ovarian, breast, and prostate, but we see them in bladder, cervical, neuroendocrine tumor, pancreatic cancer, endometrial, the one that had treatment with platinum base. Yeah, I will share it in the chat. Thank you so much for giving me time.
Thank you. Thank you so much.
Yeah, maybe I can ask or really ask a question, not only comment. I wonder, did you test samples, for example, after chemotherapy, if, for example, cisplatin therapy, it uses breaks that can be mistaken as genomic scars from HRD? So have you any experience if you really need pre-treatment samples for detecting HRD correctly?
Actually, we have the most of our samples are taken from the surgical specimen, which is usually after the therapy has been given. The patient has received chemotherapy, and after a few cycles, then the surgery is done. So especially for stage 4, stage 3 and stage 4. So yes, most of our samples are post-therapy, cisplatin therapy.
Maybe I can comment on that. There's a big study in Germany going on, the TRUST study, where they actually compare surgery before and during chemotherapy. And we do have the data available also for sequencing, so we can actually check there for this kind of information at some point. But this is an ongoing study. It's really the question of like when to do the surgery in ovarian cancer. So we have pre-treatment and mid-treatment data. Right. Are there any further questions?
So I have a question, I guess. So you had gone in detail with the two kind of approved assays, Myriad and Foundation. I know just through looking at posters at several meetings and things that there are a lot of institutions that are trying to validate their own kind of HRD algorithms. And how do you see that playing out? And do you think that they're going to be comparable to something like a Foundation Medicine or a Myriad at this point?
Look, I think there is already something like for TMB found this Friends of Cancer Research like collaboration going on for the different assays. But I don't feel it is feasible for everybody to get the foundation. At least in India, I know they are very costly. So it is not possible. So nobody will get it done. So there are very few who can afford that kind of thing. So we also have validated our tests and with few sample, and we tried to take the lower cutoffs also, so that which are close to the lower cutoff 42, so that we can come up. And that's why we have found that 65 is a good cutoff. So we are not reporting, but yes, we should have our own, and it is not possible. In most, I don't know, at least in our part of the world, it is very difficult to have that. You have to have your own essay.
Right. And then how does turnaround time kind of play into everything? What's the actionability window for a lot of these patients?
So turnaround time at our institution is around 3 weeks, but we usually give out the reports in 2 weeks. And that's because of the volume we have. So we are able to do that. And that's the turnaround time, because they need to, after the surgery, they need to start if they have to start. So they need 3 weeks, not before that. They will start any kind of therapy. So that's good for them, most of them.
Good to know. Thank you.
Okay, I don't see any further hands. Are there any more questions? You can also just chime in or write them in the chat. Maybe one quick question. You said really in the beginning, you showed this overview on mutational signatures and how they actually play out in panel sequencing. Can you comment a bit on like how many genes would be necessary to actually identify HRD mutational signature?
So
like how big the panel
this
would
is
have to
not
be?
based on genes. The signature is not based on genes. That's type of mutations like C2T or G2A. So if you have more of these kind of, so it may be in different genes. So that's not based on that. And not only the single nucleotide variations, but it is also based on copy number changes. So that's why I think the overall there is, you're looking at the bigger picture for HRD score. You're looking at some bigger losses or gains somewhere or breaks, because if there are so many things happening, so lot of things. So I think it's based on that kind of thing. It's not based on mutations.
No, but
Though
but usually
yeah,
panels are
HRR
based
gene
on
mutation.
genes. Panels are based on genes, and I was wondering. So really in the beginning, you had an overview, like in the first couple of slides, that one could basically, go for mutational signatures also on a panel size, and then the question would be how small can your panel, or like how big should your panel
Look,
be?
for your mutational signature, you will need lot of SNPs to be covered. I think you will be a better person to answer that. So you need some 40,000-50,000 SNPs which have to be covered, which can give you an idea of these LOH or TAI or LST. So that kind of thing is based on this. So SNPs are mainly for that. And plus the HRR genes. So there are usually these 14, 15, which are common to most of the HRR gene panels. And again, as I told you, there is no consistent list of HRR genes. So nobody has told that, okay, these are the HRR genes. So, and everybody has used their own, but there are some genes which are common to most of the panels. So at least they should be there. That's what I feel.
Okay,
But
so yes, so you didn't dive deeper into that topic on how small a panel could be if one goes not more really just for a gene panel and wants to basically cover it.
just for the panel can be small. I feel you only need SNPs if you're not looking for the genes. If you don't looking for the HRR genes, the panel will not be very big. Only thing is if you need a lot of SNPs, so that will not make a big panel. That's what I understand. I'm not a bioinformatician, but maybe you can answer that part.
Well, we've been looking at panels and trying to identify like what's basically the tumor mutational burden you need or the panel size to actually find sufficient information on mutational signatures. I was just curious whether you had any insights on that.
If you want, I can like go and peep into it.
No, that's okay. We would do that. I mean, we're doing that.
Personally, I actually, my work is mainly clinical and reporting. So yes, but I try to understand. I find it very fascinating when bioinformaticians are talking, but I understand it very less. I'll be honest.
It
I
just
feel
caught my attention.
overwhelmed by the numbers and the things and the black screen that they keep on showing you.
Yeah, okay. Yeah, sorry for this sidetracking now, but it just caught my attention in the beginning of your presentation. Okay, I don't see any further hands. Thanks so much for joining.
Thank you. Thank you.
Thank
for
you
the
so
opportunity.
much.
Thank
Yeah,
you.
and thanks for this great discussion at the end. It was yeah, very interesting, and I learned quite a bit.
Thank you.
Yes, thank you so much, and happy holidays, everybody. I
Thank
think the
you.
next time we get together will be in January. So yeah, enjoy time with families and celebrations, and we'll see you in the new year.
Yeah, thank you.
You as well.
Thank you.
Happy holidays.
Happy holidays.
Yeah.